Well, good evening, everybody. I think we've let everybody in. Can I welcome you to the 2021 Sachs Institute Research Action Awards. My name's Don Nutbeam, for those of you who don't know me, and I'm going to try to guide us through this evening's proceedings. I'd like to begin by acknowledging the traditional Aboriginal custodians of the land on which we variously meet. In my case, I'm on the Gadigal lands of the Great Eora Nation, and I'd like to pay my respects to elders past, present and emerging, and particularly welcome any Aboriginal and Torres Strait Islanders who are joining us this evening. I'd particularly like to acknowledge and welcome the Chair of the Sachs Institute Board, Professor Ian Olver, and of course the Sachs Institute Chief Executive Officer, who's told me that she's successfully delegated everything this evening and won't be making a personal appearance. So Sally, well done. I wish I had your delegation skills, but it's great to have Sally Redmond with us, the Chief Executive of the Sachs Institute. I should also mention, of course, Elizabeth Koff, who's I think attended as many of these as she's been Director General, and she will be joining us tonight. Unfortunately, not in person because of another commitment, but she has prepared a pre-recorded message for us, and we look forward to hearing from that, soon. We also have some incredibly distinguished panelists joining us for a discussion a bit later in the process. I'm delighted to have Dr. Teresa Anderson with us, Professor Catherine Bennett, and Professor Andrew Wilson. I might say, straying a long way from my notes, that when we were talking about plans for this evening, I was asked who I thought would make a great group of panelists to talk about the life post-COVID. And I said, Teresa, Catherine and Andrew would be ideal, but I doubt very much we'd be able to get all three in the same place at the same time. I'd have to say, feels like I got the dream team this evening, and I'm looking forward very much to the discussion with you later. I should mention to everybody that the meeting is being recorded. And just remind everybody that these Research Action Awards really go to the heart of the mission of the Sachs Institute, which is to improve health and well-being by driving the use of research in policies, programs and services. And certainly this evening in particular is an opportunity to recognise researchers whose work has had a significant impact on health policy programs or service delivery. And it does provide, I think, for the Sachs an opportunity to celebrate our research community and all that they've achieved, particularly over these past couple of years when, firstly, the community has had to respond incredibly deftly to some of the challenges that have been thrown up by COVID, and have also had to adapt to continue their already planned research in extraordinary circumstances. I'm now, following Sally's example, I'm very keen to hand over to Professor Ian Olver, who's going to give a welcome address to us. Many of you will know Ian as a cancer researcher, medical oncologist and bioethicist, currently Professor in the Faculty of Health and Medical Sciences at the University of Adelaide. His past positions include being Director of the Royal Adelaide Hospital Cancer Centre, CEO of the Cancer Council of Australia, and Director of the University of South Australia Cancer Research Institute. He's a past President of the Medical Oncology Group of Australia and was the multinational and the Multinational Association of Supportive Care in Cancer. He was appointed a member of the Order of Australia in 2011 for services for medical oncology. Ian, over to you. Great to have you with us.
Well, good afternoon, and thank you, Don, for that introduction. I'd like to begin by acknowledging the traditional Aboriginal custodians of the lands across the country, wherever you may be attending from today, In my case, it's the Kaurna people of the Adelaide Plains, and I pay my respects to their elders past, present and emerging, and recognise the diversity of Aboriginal and Torres Strait Islander people and their ongoing cultures and connections to the land and water. I'm delighted to welcome you to the Sachs Institute's 2021 Research Action Awards. As Don mentioned, the Research Action Awards are a special event in the Sachs Institute's calendar. They're a very tangible way in which the Sachs Institute seeks to deliver on our message of encouraging research that impacts on policy decisions, and we're very proud to support them. But more than that, the Research Action Awards exist to inspire as well as honour Australia's early career researchers who are interested in working in partnership to change health services and policies for the better. Look, we regret we cannot hold this event in person for a second consecutive year due to the ongoing pandemic. It's nevertheless wonderful to see so many of you sharing this celebration with us. Now, in a moment, I'll introduce the video address from Elizabeth Coff, the Secretary of New South Wales Health, and although, as you know, she can't be with us tonight, we thank her for the time in preparing the message, which we greatly appreciate. It also gives me great pleasure to welcome our distinguished speakers, Dr. Teresa Anderson, CEO of the Sydney Local Health District, Professor Catherine Bennett of Deakin University, and Professor Andrew Wilson, Co-Director of the Australian Prevention Partnership Centre. Just as we started to think that COVID was beginning to pull away from us and be a vision in our rear view mirror, along comes another variant to put it back in the centre of our attention. And I'm sure that the panel discussion we have planned will help us to make sense of the main questions and challenges as we seek to return eventually to a life that approximates what we knew pre-pandemic in 2019. So I look very much forward to the discussion, and I thank you all for making time to be with us this evening. And of course, I extend a special welcome to the two winners of tonight's Research Action Awards. I'm really delighted to note the quality of the applications, which continues to be exceptionally high. I'm sure you will shortly see this for yourselves, and when we provide an overview of their winning projects, it'll be obvious they are truly quite special. May I thank the members of the Assessment Committee for their time and expertise in the process of judging the applications. The panel was chaired by Professor Paddy Phillips of Flinders University, and members were Professor Annette Bowes from the London School of Health and Tropical Medicine and Professor John Lavis of the McMaster Health Forum in Canada. We extend our deepest thanks to all three, and I understand that Paddy and Annette have joined us tonight, so I especially welcome both of you. As has been the case since 2018, one of tonight's Research Action Awards is dedicated to our missed colleague, Associate Professor Sonia Woodsky, who played an invaluable role across many areas of the Institute's work and who was central to the success of the Australian Prevention Partnership Centre. We are delighted to welcome members of Sonia's family who are also joining us tonight. Sonia was strongly committed to research that made an impact in improving both health policy and services. So she supported and developed early career researchers and other staff, and this was one of the things that gave her most satisfaction. Thank you for joining us, and I hope you enjoy the program. So I'm now pleased to introduce, albeit virtually, Elizabeth Coff, Secretary of New South Wales Health, who has provided us with a video address.
Good evening, everyone. I'd like to start by acknowledging the traditional owners of the land on which I'm located this evening, the Camaragal people of the Eora Nation, and pay my respects to elders past, present, and emerging. I'm pleased to be able to join you tonight, albeit remotely, for this celebration of the role and value of research that achieves a positive impact on health policy. Tonight's event continues a fine tradition seen right across the health system of acknowledging our talented researchers whose work makes a real difference. From the beginning of the pandemic, New South Wales Health recognised the role that research could play in helping to guide the New South Wales Government's pandemic response. And it was with a great sense of optimism we tonight are exploring how research can help us to recover from COVID-19. It is clear the role of research continues to be vital as the pandemic's course shifts into a recovery phase, we all hope. I have no hesitation in reaffirming that here in New South Wales, we had a strong public health foundation on which to build our response. The public health infrastructure in New South Wales is rightly seen as a great strength of our state, and I pay tribute to the many leaders and stewards of the system whose decisions over the years have allowed this depth of expertise to develop and grow into the nationally significant asset it is today. I shared with you at last year's awards event some of the specific steps put in place by New South Wales Health when the system's need for new information about COVID-19 to inform policy settings became so urgent. These included the multidisciplinary COVID-19 Clinical Council, which was set up to create a channel for rapid engagement with clinicians across the health system and allowed issues to be rapidly escalated while providing expert advice at the operational level. A further innovation of which I remain especially proud is the Critical Intelligence Unit, which was established as a non-decision-making resource at arm's length from operational functions to provide objective, real-time advice in line with changing evidence base. But in the context of a novel disease, generating local knowledge was always going to be important. And this was made a priority with the New South Wales Government's allocation of $25 million in April last year to fast-track research to support the COVID response and recovery. Some elements of what became the Emergency Response Priority Research workstream are well known and rightly applauded. For example, the NC's seroprevalence study in schools influence policy Australia-wide by contributing to decisions to allow school children back into classrooms in mid-2020 and also shaped policy around higher-risk school activities such as singing and overnight trips. Meanwhile, the wastewater monitoring program, which I'm pleased to note has won several awards for its design ingenuity, has proved enormously valuable in directing attention and resources during the pandemic's progress. Findings from the program have enabled New South Wales Health to target messaging and testing to high-risk COVID areas, tracking possible COVID-19 clusters and outbreaks, and managing movement restrictions following a known outbreak. But there are other less well recognised elements of the research program that deserve attention also. These include the new mechanisms adopted to allow research to inform and influence policy development more quickly. One of these is the embedding research personnel in New South Wales Health to work directly with New South Wales Health datasets to inform the pandemic response, with an example being the COVID-19 New South Wales Outcomes Study. And of course, New South Wales Health was also able to generate valuable new insights into community experiences, attitudes, and knowledge by harnessing the rapid turnaround capability of the wonderful Sachs Institute's 45 and Up study, one of the largest cohort studies in the world, covering around 1 in 10 New South Wales adults over the age of 45 through its valuable COVID insights work. Overall, I'm very proud that New South Wales was able to ensure the agile response of our talented and experienced researchers working in close partnership with us ensured health decision makers have had the best possible local evidence on which to base operational decisions. And as Secretary of Health, that couldn't have been more important to me. The final note I'd say, the future is looking very bright for research continuing to inform policy in New South Wales Health. Thank you and congratulations for the evening.
Well, I should say immediately thank you to Ian for his introductory remarks, and of course a special thank you to Elizabeth for her remarks and continuing support for the Sachs Institute and continuing support for research. It's a real pity that Elizabeth's unable to be here in person, because this always provides us with an opportunity to acknowledge the extraordinary leadership that she's provided over the past couple of incredibly challenging years. And as she outlined in her address, despite all the pressures that those providing leadership in our system have been under, at every step along the way, they have committed to mobilising the research assets that we have in New South Wales to fill gaps in our knowledge, set up a system to ensure that we have a way of collecting the best available evidence, synthesising it and making it rapidly available to those who are making decisions about policy and clinical practice. And then most importantly, actually using that information to guide our response to the pandemic. It's been an impressive process in New South Wales, and as she rightly pointed out, it's a process that's attracted interest nationally and internationally, and all of this of course has come under her stewardship. So I'd certainly like to acknowledge that leadership that Elizabeth has provided and continues to provide for all of us throughout these very difficult times. So we're now going to move on to the heart of our meeting this evening, which is to make our 2 awards. I think Ian provided a really good overview of the purpose of the awards and reminded us of 2 things really. Firstly, a pretty rigorous process for assessing those applications that we received, and a reminder that we had some really outstanding applications to choose from, and it's always a pity in these situations that it boils down to only 2 awards, because I'm quite certain there were others who have put forward to us some very important research that they were undertaking. But it only goes to emphasise just how outstanding the 2 award winners were. So it's my pleasure to invite Ian back now to announce the first of our Research Action Award winners for 2021.
Thanks again, Don. It gives me great pleasure to announce the winner of our first award this evening, Dr. Ben Bavington. Dr. Bavington is a Senior Research Fellow at the Kirby Institute, University of New South Wales, and his award recognises his work titled Opposites Attract, demonstrating the effectiveness of HIV treatment as prevention. Congratulations, Ben, and I invite now all of you to watch a video of Dr. Bavington talking about his winning research.
Just really so pleased to receive this award. It's such a great honour. I work in the area of HIV prevention, and I think over the last couple of decades actually, HIV has sort of fallen off people's radar a little bit, which is a shame because there's been so many amazing advances that have been happening both in the area of HIV treatment but also in prevention. My research is in an area called HIV treatment as prevention. So this is the concept that if a person living with HIV is on highly effective HIV treatments, they can get the virus to an undetectable level in their body. And this can then mean that it's impossible for that person to pass on HIV sexually to a partner. So quite a few years ago now, about a decade ago, HIV treatment as prevention was proven completely in heterosexual couples, but it wasn't proven in men who have sex with men. So my research was called the Opposites Attract study. And in this study, we enrolled 358 male couples where one partner had HIV and the other partner was HIV negative. Over follow-up, we analysed over 16,000 acts of condomless sex within these couples, and we saw no instances of HIV transmission. And this was because the positive people in the study were on HIV treatments and had an undetectable viral load, and that meant they couldn't pass on the virus to their HIV negative partners. These results have really revolutionised HIV prevention globally, and as a result, we've seen a lot more people get onto HIV treatment. One thing I'm really proud about is the way that Opposites Attract has played a role in reducing HIV stigma. HIV stigma still gets in the way of people coming forward for HIV testing, HIV treatment, and also HIV prevention. So anything that we can do to reduce HIV stigma globally is going to have a really big impact. First and foremost, I'd really like to thank the study participants in Opposites Attract in Australia, Brazil, and Thailand. Work like this is impossible if people don't come forward and volunteer their time and their energy, and particularly people living with HIV. We wouldn't have made the advances that we've made over the last few years without people participating in studies like this. Of course, there's been a lot of people that have supported both myself and also this study. I'd particularly like to thank my supervisor, Professor Andrew Podger, at the Kobe Institute for supporting my career and allowing me to be the project leader of this study. And also our network of clinical sites, the labs, the community-based organisations, and of course, all the study investigators.
Ben, thanks. That was a fantastic little video, and it's easy to see why you won the award from watching that. Absolutely outstanding research, but of equal importance to us. Really impressive impact from your research that's benefiting members of the community in very, very practical ways. So Ben, I would invite you just to say a few words. I'm going to put you on the spot a little bit and say, as a part of that, would you like to tell us what's next, and what's really important on the horizon in HIV research from your perspective?
Absolutely, thank you very much, Don. So I'm speaking tonight from Gadigal land, and just let me extend my thanks to the Sachs Institute for awarding me this amazing honour. It's just so great, thank you. So in terms of HIV prevention priorities, I think now that we know that HIV treatment as prevention works, we just need to get more people onto treatment who need it and to understand the barriers to this. So in Australia, we're fortunate that we have really high treatment uptake, but this is an important global research agenda that we mustn't lose sight of, including in our local region. But the Achilles heel of HIV treatment as prevention is the transmissions that occur because people living with HIV don't know that they have it, that is, they're undiagnosed. So in this area, a top research priority is to continue to understand and dismantle barriers to HIV testing, and especially HIV stigma and stigma towards key populations who are at risk of HIV. So this is becoming a major focus of our HIV prevention work here in Australia and overseas. And ultimately, what we need is effective HIV prevention tools that are in the hands of HIV negative people. So my main focus now is on something called HIV pre-exposure prophylaxis, or PrEP, which is when an HIV negative person takes medication that stops them from acquiring HIV. And there's a very large research agenda in this space, including understanding how to get more people onto our existing PrEP options, but also researching the effectiveness and implementation of a whole host of new products in different forms that are coming down the pipeline over the next few years. So it's a really exciting space to be in, and especially so because we're getting really serious about the possibility of eliminating HIV transmission in Australia. And this is reflected in the ambitious national and state level HIV strategies and policies that we have right now. So there's a lot of momentum in our field, and it's really fantastic to be part of it. So once again, my heartfelt thanks to the Sachs Institute and to all the people that made this research possible. Thanks very much.
Ben, thank you very much, and a really encouraging I think, view of what's next and what the future holds, and a reminder, of course, that understanding human behaviour and its place in society remains a really important challenge for us to address. So thank you very much, and congratulations again. As I said, it was easy to see why you were successful this evening. I'm going to pass back to Ian now, who's going to introduce our second award winner this evening.
Thanks, Don, and congratulations again to Ben. I think the video showed the importance of that research. And now it gives me great pleasure to announce the winner of our second Research Action Award this evening, and the winner is Clara Wood. Dr. Blewett is a research fellow in the Health and Social Care Unit in the School of Public Health and Preventive Medicine at Monash University. Her award is for her research project entitled SEED, an intervention to address social and emotional difficulties in early childhood. I'd also like to note that Dr. Blewett is the recipient of the award that is dedicated in honour of Associate Professor Sonia Wutsky, the former Deputy Director of the Australian Prevention Partnership Centre, who was also a member of the Sachs Institute's executive team. Congratulations, Claire, and I now invite all of you to watch a video of Dr. Blewett talking about her award-winning research.
I'm so grateful that our research has been recognised by this award. My work has revolved around social and emotional learning in early childhood. We know that around 1 in 5 Australian children will experience difficulties acquiring the social and emotional skills that are so critical to a fulfilling life. So these are things like being able to recognise and understand their emotions, show empathy, be aware of themselves and others, build friendships and make responsible decisions. It's an area that has seen a lot of research in children of primary school age, but less so in younger children. So I am so thrilled that this important part of early learning is being recognised through this award. I was very fortunate to work with a really terrific team of people involved in a range of aspects of early childhood, including early childhood educators, primary teachers, psychologists, allied health practitioners and developmental psychology researchers. And together we developed a digital platform that supports teachers and educators to foster the social and emotional skills that young children need as they go through life. It's called the Social Emotional Engagement and Development Program, or SEED for short. Above all, SEED is really a practical tool, so it's delivered through 10 modules and provides educators with strategies that they can embed into their everyday practice, interactions and environment to strengthen children's social and emotional skills. We teamed up with Best Chance Child Family Care to build SEED, and together we've offered the program to over 70 kindergartens throughout the state through the Victorian Government School Readiness Funding. So the program is very much in active use.
Hello, my name is Padmini and I'm a kindergarten teacher at Dandenong West Primary Kindergarten based in Victoria. We started the SEED program in early 2020 and it could not have come at a better time as we were going through the first wave of COVID and many of our families had become even more isolated and disconnected with our service. SEED was able to provide us with numerous strategies and tools which were very practical and easy to implement. It didn't require any fancy resources or equipment, and it could be put into action the very next day.
We published a landmark systematic review and meta-analysis, which was the first to show that universal social and emotional learning programs can be an effective way to increase social and emotional competence and also to reduce behavioural and emotional challenges in children aged 2 to 6 years. I think early career researchers in public health are really the future of our own health as Australians. They will be the ones working with other early childhood professionals grappling with issues such as how to ensure all young children, but especially those who are experiencing disadvantage or other risk factors, develop those social and emotional skills that they need to thrive throughout life.
Well, congratulations, Claire, another outstanding example, and again, very easy to see why you were selected for the award this evening. Many congratulations. One of the observations I make is it's been a while since I was a parent of young children, but I do know that everybody wants to offer advice when things aren't quite right, and often they'll offer advice even when things are going well. I wonder what's special about bringing a public health perspective to that set of challenges, because it's a complex picture, I think.
Absolutely. Thank you so much. And I wish to acknowledge the traditional custodians of the lands that I'm joining you from today, also the Wathaurong people in southwest Victoria. I also just wanted to start by saying thank you. I'm incredibly grateful for this award and feel very privileged to receive it in recognition of Associate Professor Sonia Wutsky. I'd also like to thank the Sachs Institute for supporting researchers in this way. I'd like to thank Best Chance, my supervisor and mentor, Professor Helen Skateris, and my wonderful colleagues in the Health and Social Care Unit at Monash University who have contributed so much to this work. And thank you, Don, for the opportunity to respond to this question. I think taking a public health approach in education, and particularly early education, can play a really important role in preventing and tackling some of the complex and pervasive challenges that impact children and their families. We know that high quality early education and care can strengthen the social and emotional competencies that promote wellbeing and also prevent chronic health problems throughout life, especially for children experiencing disadvantage and other risk factors. And it also offers a pathway to reach nearly all children at a really critical stage in their development. So in several ways, the sector already draws on public health principles. So for example, educators deliver pedagogy and programs that aim to benefit all children, but also tune into the experiences and needs of each child, so are very well positioned to support early intervention when needed. However, like all sectors, it's a complex environment and there are barriers to implementing system-wide and multi-tiered approaches. So I think there is a terrific opportunity to work in partnership with the early childhood field to understand and address some of these barriers through cross-disciplinary research, and that this can potentially help to break down some of those silos that can exist between disciplines such as health and education. I think it's also maybe important to recognise what other sectors, including health, can learn from early education. They are really leading the way in areas such as child-centred practice and inclusivity and holistic support of children and families within complex systems. So I think maybe the learning and benefits could potentially go both ways. But thank you so much again for this award. I'm so grateful. Thank you.
Claire, thank you very much, and some very thoughtful words of advice and explanation that we can all take away with us. And can I congratulate both Ben and Claire again on behalf of the Sachs Institute. It was a competitive process and it's really obvious as to why they came out on top. I've had one or two frantic text messages sent to me to tell me to move back a bit from the screen and to stop touching the desk because everything wobbles. So my apologies if I've come across as a slightly manic, dysfunctional individual. I'm now going to sit away from the desk and not touch anything for the remainder of the programme. We're moving on now, though, to the panel discussion, the focus of which is on learning to recover from COVID-19. You've heard a very optimistic appraisal of our future from the Health Secretary, from Elizabeth Cough. And I hope we can pick up on that slightly more optimistic flavour through our discussion this afternoon. As I mentioned earlier, I'm really delighted with the three individuals who've kindly agreed to join us as panellists this evening. I suspect that they're known to most of you, but I will offer some introduction. So Dr. Teresa Anderson is a great colleague, Chief Executive of Sydney Local Health District, a very substantial experience as a clinician and health services executive, and a well-deserved reputation for implementing strategies to foster innovation in best practice and in supporting research in her local health districts. She's also an internationally recognised speech pathologist and passionate about developing programs and services to support and improve the health and well-being of all people in the community. Dr. Anderson is also a fellow of the Institute for Public Administration in Australia, and in 2018 was appointed a member of the Order of Australia. Professor Catherine Bennett will be well known, I suspect, to many of you. As chair in epidemiology at Deakin University, trained in epidemiology and population genetics. Her career has cut across university and government sectors, state, and she's had state and Australian government roles. She was an Olympic public health coordinator for Northern Sydney prior to returning to academia at the University of Melbourne, and her current role at Deakin University. Her research includes a longitudinal cohort study of the household transmission of Staphylococcus aureus, and a number of course, I think we're very familiar with a number of COVID-19 related studies. And finally, Professor Andrew Wilson. Andrew actually wears many hats, but he's co-director of the Menzies Centre for Health Policy and Economics at the University of Sydney, and co-director of the Australian Prevention Partnership Centre, which is based here at the Sachs Institute. He's also chair of the Pharmaceutical Benefits Advisory Committee, and his research interests concern the application of epidemiology to informing decision-making in clinical medicine, public health and health services policy and planning, especially in chronic disease prevention and management. I forewarned the panelists that I was going to ask a single generic question of each of them to get things going, and to allow a bit of time for people to pose questions of their own. If not, I shall frankly pick and choose from among the questions I want to ask them all, because I've got a long list of things that I would like to ask them now that I've got them on screen. But the advance warning I gave was simply an observation that, of course, over the past 2 years, there's been an enormous, of necessity, there's been an enormous amount of innovation in both prevention and clinical practice, always on the basis of best available evidence. And it's fair to say that on the run, we've learned a lot. And I asked the panelists if they could reflect on, you know, from their perspective, what are some of the most important things that we've learned through rapid applied innovation, and what would benefit from some further research going forward. And Teresa, do you mind if I start with you?
Thanks, Don. I'd just like to congratulate Claire and Ben as well. Fabulous research, and it's great to be here. There's so much that we've learned in the last 2 years, despite the fact that I feel like I've aged about 100. But I mean, don't we all just love the fact that the community loves data now? And I actually think that's a really huge innovation. That the community loves data that makes sense and helps to inform it to change behaviour. And I think from a public health perspective, understanding how we can change behaviour to answer those really big questions and health issues that we've really struggled with, the impact of tobacco, the impact of obesity and overweight. If we can do it with COVID, I'm absolutely positive we can now take those learnings to tackle those other health issues, and having data that's meaningful to the community. And as I said, looking at the impact of that. I think the other thing for me that's been a real innovation, but really isn't, is around the use of micro strategies to deal with the health issues of our particular communities, and understanding that there isn't just one methodology that's going to work for every community that we deal with. And the very important role of our community leaders working side by side with us to make social and health change. And I don't think we've done that as well historically, and we've seen how amazing it is. You know, if you look at the work that's happened across New South Wales and in my own communities in Canterbury, the most fabulous people working side by side to get a vaccination rate that nobody thought, Catherine, was going to be possible. I mean, it's amazing. And again, if we can do it with COVID, we should be able to do it in other areas. And obviously, the other is around virtual care and the use of remote monitoring to complement and enhance our face-to-face care. There's so much research for us to do to look at the efficacy of the different interventions with different cohorts, and it's not a one model fits all. But, you know, we've moved forward in 2 years in a way that I did not think was possible. But there's so much more research to occur about what works and what doesn't, and how are we going to be really effective in these interventions, not just make people feel good.
Thanks very much, Teresa. Great answers, and all of them worthy of further examination. But it's been, if there's an upside to all of this, it's been a tremendous stimulus for advancing innovations that were in the wings, and I think you've highlighted three that are really important there. Catherine, can I ask you next?
Well, Teresa's taken some of mine.
That was always the danger.
I do think the data one is a really interesting one, though, because what we looked at was actually realizing that not only had our pandemic plans really focused very specifically on flu, and perhaps, because they hadn't really been put to the test, probably didn't cover some of the things that we hoped we'd have covered. And now we've learnt about, whether it's furloughing staff in aged care and trying to backfill from hospitals and all the other things that are the true complexity of a pandemic that sometimes you just don't see until you're in the thick of it. But I do think actually trying to just scale up public health was such a challenge. And we had, and in particularly my own state in Victoria, Wurundjeri land and Bunurong land of the Kulin Nations, but we really did struggle in the second wave in Victoria because we had, arguably a pared back public health department that really was extraordinarily rebuilt on the fly. And I think we probably never give due credit to those people on the ground working in those departments when everything from the most basic things like the IT infrastructure was being rebuilt and set up and trying to somehow transfer to a new system. And that was incredibly important because, as Teresa highlighted, data was so central to this, and they were part of the messaging, and that indicator that what we were doing was working. And that's an incredibly important messaging for the community. And I think it's the thing that could have perhaps taken us away from perhaps a bit more of the fear messaging that we saw, particularly in 2020, to something that we all know is health promotion or public health best practice, which is actually about control and really building that, but actually having data central to that. So I do think there was a lot of innovation. I don't think we're there yet. I still don't think we can get the data out of our systems in real time to help the epidemiologists managing the outbreaks, let alone some of the more sophisticated research. And I think, as we heard from Elizabeth earlier, extraordinary work done in New South Wales to set up very early a partnership with researchers in a different way. I think that's what we've got to think about in the future. And I do think, there's so much that's learned from building the infrastructure right through to building our megastructure and hotel quarantine, how we actually physically build aged care facilities. I was talking to an aged care group earlier today, and some of them are now looking at moving to village style, complexes. All the things that could in fact help us build a more resilient future that are coming out of innovation over these last 18 months in rather desperate conditions.
Thanks very much, Catherine. Of course, I have selective hearing, so I always hear the things that I wanted to hear and then repeat them. Apologies if you can hear loud thunder here. That's because we've got loud thunder and a major storm across the centre of Sydney at the moment. The one thing, of course, that caught my ear was the challenge we've had throughout the pandemic of taking things that we've not done or done well previously and scaling them up at pace and understanding those processes better. I think that we've learned a lot, but I don't know that we've systematically captured the learning from that. And for me, that's something we need to understand a lot better going forward, both so that we're prepared for any future pandemic or emergency of this kind, but also because actually the science isn't as well developed as it might be in how you implement at scale and pace. Andrew. Andrew, you're on mute.
That is the sort of biggest learning, isn't it, of the whole COVID epidemic and the move to the virtual environment. all of us still have to be reminded at times to unmute as part of the process. Look, thank you very much for this opportunity to talk about this topic, Don. I think we need to have these conversations. There's been so much that we have learnt or unlearnt in the last 2 years that if we don't take this opportunity at this time to have these sorts of discussions, there's a real risk that we'll return to the epidemiologist in me refers to it as the regression to the mediocre, that we'll go back to business as usual, and lose all those opportunities and things that we've developed during this period of time. As I said, when you sent around the question, however, for me, one of the things that's most struck me during this period of time and is how much we had forgotten about things, about how we would respond to things, and how much we had forgotten years, decades more of public health and clinical practice in states of emergency and how we respond to these different things. There's no doubt that this has been an extraordinary challenge. It's been a challenge which came very rapidly on us. But on the other hand, there is no time in history when we have been in a period of time where in the space of 12 months, we developed at least 3 effective vaccines within 6 months, and now we have a plethora of vaccines. We have antiviral agents, we have MABs, which are going to be part of our armamentarium response to this in an extraordinary way. It reflects the level of scientific development and on a global stage, which is pretty extraordinary. But coming back to the things which are at the heart of the things that I'm interested in, and I might note that in the heart of the things that Sonia Wutsky was really involved with me when we were both working in the prevention centre together, and that is the issue of understanding the public health and public health crises, public health issues from a systems perspective. And if you think about it, just about every aspect of COVID reflects some form of complex system and requires and would be best addressed when we think about them as complex systems. That's even includes the origins of this this virus, which we need to understand in terms of a breakdown of systems. It's part of it almost certainly linked to the changing environment in which we live in that regard. But as people have gone through this and started to understand there was no simple response, there was no one thing that we could do, and that when we did do some of these things, that they had contrary effects to what we expected them to have, then that whole notion of complex systems thinking became part of that. There are a couple of things that I think, a couple of real important lessons for me that came out of it, that really positive things. I think it also forced us to start to think as one health system. There's been a tendency for us to think about public health and prevention over here and clinical medicine over here. And in fact, in this situation, we've actually had to come together and to think together about the best ways of addressing this, and because of the size of the problem that we were trying to deal with in relation to it. A third thing for me is that public health and prevention have always been really good at borrowing good ideas from places and applying them. And it doesn't matter, we're pretty agnostic as to where they come from, in fact, in terms of our application of what those are about. So if there's new developments, for example, as rapid developments in virological diagnosis, the whole genomic profile, being able to fingerprint a virus as to where it's come from, then we'll adopt that into our epidemiology and understanding of the disease and look at how we might utilize that. And we could probably go further in that. We probably haven't gone as far as we can, but it certainly has created an emphasis. Learning from what we did in HIV, where we had very effective introduction of programs in HIV, behavioural adaptation programs, but we soon learned within that it wasn't going to be enough. and that we were going to have to use things like antivirals as part of that program. And that has become an extraordinary part of the control of HIV, has been a combination of behavioural change as well as the use of these antiviral agents. The benefit we've had in relation to COVID, which we haven't had in HIV yet, is that we've also had very effective vaccines become available to us in relation to us. And then I guess the last one I just touch on, the things that we haven't learned or we've had to relearn is that we're only as safe as those people who are least protected in our society. And that's a global issue. We remain unsafe from COVID because we still haven't vaccinated a very large proportion of the world. And we are seeing that now with the new variants appearing in Australia. I don't know that the full vaccination would have protected it from us, but I think it would have helped a large degree. And then within Australia, we remain vulnerable because there are still groups which are vulnerable within Australia.
Thanks very much, Andrew. I think it was both a reminder that we need to dig backwards and remember what we learned from other experiences that were relevant here, but also looking forward. I think you're right. People understand complex systems thinking in a way that I wouldn't have expected a couple of years ago, to be honest, and people have got the idea that we have an awful lot of moving parts to be able to understand and manage forward, basically. So we've got one or two questions.
I think it was Teresa that said. I think it was Teresa, or it might have been Catherine that referred to the sort of community getting excited about data. But
yes.
I think most people would never even heard of what modelling was about. That was something either showing off the latest swimsuit or something you did as a hobby. So another aspect of community education, which I think we've got a long way to go to get people to understand what modelling actually means.
Thanks, Andrew. A couple of questions coming through. One, I think I'll direct at Teresa in the first instance, but from this point on, any member of the panel can comment on anything, basically. But one of the challenges that seems to have emerged is that people have deferred engagement with prevention programs, screening. People are obviously experiencing some deferral of non-urgent surgery. People have not attended A&E, not attended general practice at the levels that were observed before the pandemic. Is this storing up a backlog challenge? And what do we need to know in order to meet that challenge? So I'll direct that at you first, Teresa, but as I say, Andrew or Catherine can always feel free to comment on that.
Thank you. Thanks, Don. And an important question. I mean, there's no doubt we're seeing across the country that deferral of non-urgent surgery is actually resulting in an increase in emergency surgery. As there's a point at which you're no longer elective, and there is a real urgency in addressing issues. And in order to be able, we really do not know yet what the long-term consequences, I think, at scale of that are going to be on the system. In order to be able to catch up, there's going to be a surgical bubble, and we've got to have good systems in place to really triage our patients. And it's not necessarily logical or easy to be able to say just because someone was a category B that now they're going to be more urgent than someone who's a category C, particularly because of the impacts of other health complications on their condition. So we really need to study that. The reality is, to catch up, we're going to have to do over 100% capacity of what we were doing before, because that's just basic numbers. And so, we're continuing to look at new models of care, looking at the impact of prehabilitation, looking at the, early recovery after surgery, looking at the impact of virtual care, on pre and post surgery, to see if we can increase some of the efficiencies to increase throughput. But it's not only about surgery, it's around people who have been scared to go to hospitals and so have delayed interventions. And we see that particularly, I think, in many of our communities that are very disadvantaged, and the fear that they've had during this time. So I don't think we've got a really good handle on what all of that looks like at the moment. And it's something that we're all going to have to work together with, as Elizabeth said, in the future. And it also gives us some information about those things that really weren't urgent as well. Those things that we know that even in some surgery, that the reality is that, you know, some surgery is of low value. This might give us an opportunity to see if there were any long-term consequences on particularly those procedures that we do see as low value. So I think there's a lot of work to be done in those spaces. But yeah,
that was a pretty comprehensive research agenda, if I might say, Teresa. And my sense is, you know, there's a lot of things that we've been thinking might be good to do that we've had to do in order to cope over the last couple of years, and understanding their effects and providing more compelling evidence around them seems to me like a really important research question going forward. Catherine, did you want to comment?
Yeah, look, I mean, that was a fantastic response. And I do think, you know, understanding why people did delay testing or screening, particularly people where it has made a difference, is going to be really important, because it's one of those perhaps unintended consequences. But it comes back to also the fundamentals of risk communication. And I think, you know, we actually went down a path which was nothing any of us would have been taught, you know, in terms of public health risk communication. It was very much driven by fear. And in Victoria, we had very strong messages that movement equals virus. It got that basic. And the people who were looking at the screening were the people who actually were vulnerable by definition, if they were going in, you know, with any concern or already had chronic conditions. And so the fact that the very people at risk of COVID were so terrified that they couldn't manage that risk and actually have a test or whatever it was required without putting themselves at further risk is disappointing. I think we got the messaging wrong there, and we have to work through that. So unpacking all of this, the research around it, is a big piece of work, but a really important one.
Right. Andrew, you look like you wanted to chip in.
Yeah, look, I'm not overly concerned at this point in time about the impacts of the COVID in relation to chronic disease. I think there are a whole range of issues that both Catherine and Teresa have referred to that we'll need to deal with. But I think, you know, we can catch those up. Where I'm concerned about is around mental health. I think the mental health burden, the impacts on mental well-being from COVID are something that I'm far more concerned about in terms of our ability to do something about it and respond to that, because I think the numbers there blow all the other ones out of profession. I think, you know, Claire Blewett's work with children, and, you know, the impacts that have been on children, the impacts on being out of school for long periods of time, the impacts on people who have been weren't in the fortunate position, such as myself, of having a job which actually got busier during this time but found themselves unemployed. You know, these impacts are something that we really do need to think about how we're going to manage those. And I think that's a much larger problem than catching up with where we were with chronic disease.
That's a really important reminder, Andrew, and again signals to me a set of research questions that we could fairly urgently move on, looking to understand in this phase what are the longer term impacts on the mental health and well-being of people. So thank you very much for that. Andrew, I'm going to stick with you just for a moment, but again, you know, I'd like to hear from Teresa or Catherine if they want to. Somebody picked up on your comment about the health system coming together as one, and really asked the questions: what did we learn from that? What enabled that, and what could we hope to preserve in the next phase in the pandemic?
So I think there were a couple of elements to it from my perspective. First one was there just hadn't been the dialogue, I don't think, previously. I think people were so busy in their different courts that they just weren't having that dialogue across it. And COVID forced them into a position of having to have that discussion. But there were also some immediate consequences which drove it. The immediate consequence of having people who may be infected turning up in an emergency department or being admitted for elective surgery or whatever, that made people have to think about those consequences within their own environment of what was happening outside. I'm not talking about there were obviously major infection control aspects, but they actually had to think outside of, oh, wait a minute, what's happening out there, or what can we do out there that will protect us in here? And so that was a very important part. Teresa could talk for ages about the work that's had to be carried on, looking after people who have been, we've quarantined. We've had thousands of people that we have essentially locked up for 2 weeks in different situations, and we've had to take care out to them. We've had to try and provide some sort of care to them in those sorts of environments, and that brought together the sort of community setting, people in the community setting with people in the sort of hospital setting in a different way to what we've done before. And some of the technologies which have enhanced and enabled that, certainly locally, have been really, a really important development in part of that, as part of that dialogue. So, I think those are just a couple of the things which have sort of started to force some of this discussion going along. I might say that I think just a comment that just going back to the previous question, but also relates to this question, is we had a response which by necessity was driven by the sort of acute care sector, by the hospitals, by and the public health, and forced the sort of public health and hospital sector into bed. Living with COVID, we're going to have to find a different model, because if we're going to go back to anything like we were required to do in the healthcare system, we can't do it while diverting all of those resources off to looking at people in the community. And we've got we've got to do some new thinking and get some new models in place for care of people in the community settings from what we've got at the moment.
Thanks, Andrew. Teresa, did you want to add to that?
Yeah, I think that's a really important point. And I think, again, one of the great things that have happened during COVID is that other government agencies, business, other industries, the community itself have all responded to this. And taking Andrew's point, there's a bit about community and how do we get community to take responsibility for their own health and well-being and help them with self-management and being able to access care in the way that they feel that they need, being able to use those other government agencies and business. I've worked with business more than I have ever in my career in the last 2 years, hotels, airlines, you name it. Why can't I use them now to help to address some of those other health issues? I think employers need to be taking some responsibility for creating healthy work environments that actually also contribute to the health and well-being of people. And that includes, as Andrew said, around mental health well-being. There is so much, I think, that we have learnt about partnership through this that we should be able to use to create interventions that are more widespread than we have historically. So it's not all about the acute health system. I think our partnerships with general practice are much stronger than they've ever been. And in terms of managing care in the community, that's critical. But we're using pharmacies better than we have previously. Why can't we use pharmacies more, education departments more, etc.?
Yeah, it's really great insight that we don't always think about. I had forgotten just how much you've had to work with the private sector, for example, in the management of people with COVID in the community, for example. And you're right, they're really good questions. What can we learn from that experience? What could we do better in the future? Seem to me to be a sort of recurring set of questions that have come from the experience we've had. But we've probably got time for one more
I was
issue.
just going to quickly add,
please, I was going to come to you.
if I might, Don, just, and it came through in Teresa's answer as well, but it's at that blurring between response and prevention, and I think that's what you have when you have a pandemic. You're cycling between waves, and what we saw, and as Teresa said, the work with industry, and I've been doing a lot of that around the vaccine programs, but also safe return to work. Earlier it was on about COVID safe plans. So it is this merging, and so that if we have those partnerships and they're strong on prevention, then it gives you a whole different platform, you know, for future risk of pandemic, let alone how you could respond in a pandemic. But same with community partnerships, and I put that to the health department here in Victoria as we moved to a localised public health unit from a fully centralised one. That I said, you know, we're actually establishing them at the end of the second wave, that we should actually build them around, you know, community partnership programs, which were about setting them up with trial runs, you know, actually having scenario testing, doing that in partnership with communities. So you train up the staff on the back of the very partnerships that were going to be critical, and that you look at prevention. And yet when we came to the recent wave in Victoria, as with New South Wales, it hit our most vulnerable communities first, largest families, casual workers, essential workers still working in lockdown, but also with the lowest vaccination rates. And I couldn't figure out how after the second wave, those same communities that we finally built these great relationships with the health department, even local public health units, that they hadn't translated to these having the best vaccination rates, particularly in the name of prevention and protection for those communities. So we got there, and it was an incredible, you know, uptake in those areas. But to me, that should have come off the back of the second wave, not the back of the third or fourth or whatever wave as well. So I just think it's that translation and keeping it live through that rolling cycle of prevention and response.
Thanks very much for the comment, Catherine. That offers me a neat segue into the last issue I wanted to touch with you, all three of you on. We've just got a few minutes left, so I'd ask you to be reasonably brief. One of the observations that I've heard consistently through the comments that you've offered, and I offer this from a slightly selfish perspective, is observing what has been a significant contraction of the typical discovery to application pipeline, the research translation pipeline. I just wondered if you could offer us a few thoughts about this has demonstrated that it's possible to significantly contract the typical research pipeline time and avoid some of the valleys of death that often occur, where you know, great ideas and innovations just simply never get going because we don't have in place a system to support them. You know, a 1-minute piece of advice on how we capture what we've learned and move forward with that. Catherine, would you like to kick us off on that?
I think it actually has been a bit patchy still. I don't think we've set up systems for it. I think it's being driven by need, but I think we've seen the value of it. So I do think that's something that we could do better with. And now it's about laying the paths, you know, to actually enable this in future. Just in terms of translation, personally, I have, you know, people from anywhere in the public who ring me up and ask me for advice. Academics never have that kind of reach, let alone the partnerships with media. But again, it's hopefully something that's shifted how people see universities and that possibility. I mean, I'm not saying every academic wants every member of the public ringing them, but we should leverage that. We should, you know, actually say that's as it should be. You know, we are there to work with the community and try and break down all the barriers between universities and the public.
I might say you have been personally an exceptional role model in that regard. I still know a large number of my academic colleagues who would run a mile if somebody turned up with a camera, but that's another issue, I think. Andrew, any thoughts about this?
Okay, just two quick ones. you know, people are probably aware I'm the chair of the PBAC, and I've been asked on several occasions by industry, you know, and patient groups for that matter, how come these drugs or vaccines for in relation to COVID have been approved so fast, and these other things take so long, and we're prepared to pay so much money for them that you won't give to us normally. I mean, I think you know, pandemics and epidemics do change the threshold at which we're prepared to adopt innovation by necessity. I mean, we were faced with potentially thousands and thousands of people dying and becoming seriously ill, etc., in relation to this. So there was that aspect to the adoption of these things. There was a willingness to take greater risks at all sorts of levels in relation to what we were prepared to do in this space.
Thank you.
I'll leave it there, Don.
But that's a really important reminder that our risk threshold dropped a bit probably during this this pandemic. Teresa, last word for you.
I agree. I think it is about management of risk, but it is also, again, it goes back to partnership with the researchers and the clinicians and the managers in real time, not as an afterthought. And I think that going forward, the real key for us is how to, as Ian said earlier, how do we embed researchers within our health services so that we've got real-time consideration of the questions that are impacting on us, and together we determine ways of being able to investigate that and come up with solutions together. And that includes the community. That's
a really great answer. Again, because of my selective hearing, it was exactly what I wanted to hear at the end. Which is finding the right way to better connect our research capability with our health system's needs, and do so by creating these partnerships between our researchers, our clinicians, and you importantly remind us, the people that actually help us to manage our health systems, those who are trying to make the system work. Alongside the clinicians who are often, frankly, a bit of an afterthought in this, but are often also the key to getting things scaled up and sustained over time. So thank you, Teresa. I couldn't have asked for a better way of finishing off our discussion. Can I conclude things in the last minute or so? Just firstly by thanking Teresa, Catherine and Andrew for a really stimulating discussion. I always knew it would be fun, and I always knew I'd have been happy to carry on for another hour, but I think people online have other plans, and we should respect that. But thank the three of you really very much. It was a great, stimulating discussion. I want also to acknowledge again and thank Elizabeth Koff and also to Ian for their contributions this evening. Congratulate Ben and Claire again as the Research Action Award winners, and thank everybody for joining us online. I sincerely hope we can come together for what's always been a great networking session in person next year. Thank you all very much for joining us this evening. That concludes the Research Action Awards for 2021.